So to not make a liar out of me, it is 8:01 and we'll go ahead and get started. Good morning, everyone. Thank you for joining. As you see up, I do have, just instructions to write your name and practice in the chat. We'll get moving forward here. It is going to be a relatively short agenda today, but lots of good information for people to walk away with. We'll just do a quick little update on some staff at AHP, and then Elizabeth Sharp is going to do a review of our 2024 quality performance. I will be talking a little bit about provider notification dates, as it is that time of year where we start to do roster submissions. So we want to make sure that we're all up to date there. And then we do have just quick updates on incentive payments and then some time for open discussion. So as we go through this, if you have anything that's kind of in the back of your mind that you have questions about, be sure to jot those down because I'm pretty sure we'll have some time to field those questions. Starting with our first update, this one is a lovely one. Many of you who work with Molly Parmenter may know already that she is out of the office on leave. So she will be gone through the end of the year. So if you do have any questions, feel free to reach out to me as you've done before. And then hopefully we'll be seeing Molly back here in the winter months. So really excited for her. But if you have any questions for me, just reach out. That is the briefest update that I have. I'm actually going to stop sharing my screen, and Elizabeth Sharp is going to take over from here to talk about quality for 2024.
Jana, that was some top-notch updates. So as Jana said, I'm going to share my screen. I have some quality measure performance updates for you all today. Can everybody see my screen? Let me give me a nod, a thumbs up. Jana's nodding. Awesome. So reminders. We have communicated this in a couple different ways, through this meeting, through network news, but it's probably not top of mind for you all. So a brief reminder, AHP is transitioning to Health Catalyst in 2024. Not all practices are connected yet, so we do have our claims data validated and in Health Catalyst, which is very exciting. And we're starting validation on the EMR data. It's a rolling validation. So not everybody is connected, and it's September 18th. So not exactly actionable in terms of getting a chance to see data in that system. So with that, we, for 2024, reminder, decided to look at our network-wide performance on our 3 different Excelis lines of business: commercial, Medicare, and Medicaid. The reason for that is we had consistent data for all 3 lines of business throughout the year. What's new? So I'm going to show you guys the scorecards by each line of business and just talk through kind of what's going on, but wanted to call out a new column that we have. So for each of these scorecards, these are the headers. We have our measure name. We have the prior year end baseline. So where we landed at the end of 2023. And we've recently built in a new column, thanks to Dr. Angelique Cohen for having the idea and to Christy and her team for pulling it off. We took a look at the closest date that we had run last year. So we could look at a year to date from last year and a year to date from this year and make sure that we're kind of in line with where we were performing last year. It's an easier way often to compare to know if we're on track. So Excelis commercial performance. I'm going to reorient everyone to this scorecard. And I have some notes on the next slide, so you don't need to be able to read this all at once. But essentially, as of 9/11, we have our Excelis commercial measures, our prior year end baseline, and then that from 9/18/23. It's a little confusing because it was like this date last year, but it's just the date that we ran our September numbers last year. We have our numerator, our denominator, our score, and the percentile. If we're not at the 90th, it shows how many gaps we need to close to get to the 90th. And then we have those different thresholds. So you can see kind of how close we are as a network to getting over those next hurdles. A couple of things that I wanted to call out. I'm actually just going to go to we have some work to be done in our diabetic and hypertensive measures. Compared to last year at this time, hypertensive blood pressure control is on par with where we were. Diabetic eyes shows a slight improvement, which is great because we know that's a tricky measure to capture. And diabetic A1C is a little bit lower than where we were at this time last year. So that is a couple of measures, a suite of measures that we're going to be paying attention to. Colon cancer screening improved over this time last year, which is great. Also not that shocking. because we did have that change in definition last year. So I think we're starting to get in more of those 45 to 50-year-olds, or we got some of them in last year and they're still counting because colonoscopies last for 10 years. We have identified a data issue with childhood immunizations. I'm going to pop back. This is one of those areas where this new column has been really helpful. So we took a look. Last year at this time, we were at 89% of our gaps closed, and right now we are only at 70%. So don't panic. There's a data issue. We're working on a fix. I'm not sure yet if this is going to be reflected in the data or if it will be a manual adjustment at year end. So we're working on that. When we have that information, we will definitely share it with you all. Do you have any questions on commercial? Excellus Medicaid performance. A little bit of a different color suite here, though I do want to call out colon cancer screening is at the 90th percentile already for the year. And that is really, really exciting. The change in age range last year really impacted the Medicaid performance in a bigger way, I guess, than the commercial and Medicare, because those were high enough above the 90th threshold that they stayed at the 90th threshold. So really, really excited to see that movement. Again, we do have that issue with the childhood immunizations and just to still work to be done in those diabetic and hypertensive measures. We are showing improvement on all three compared to this time last year. So that's another sort of exciting thing. There's a lot of good work being done in this space. Focusing on our Medicaid performance is certainly something that AHP is interested in, particularly from an equity perspective. I'm going to jump over to Medicare. Slightly different color scheme here. So you can see the year-end baselines, 90th and 75th percentile. The year to date, obviously, we have some red in there, but we are showing an increase in diabetic eye over this time last year. That's been a consistent theme. That's really, really exciting. Thanks to all the good work that everyone is doing. And the fall risk management has decreased, but is still at that 90th percentile. So all things considered, we are paying attention to, I think that's the end of my slide, so I'm going to stop sharing. We are paying attention to our quality measures. We always do, but particularly this time of year to see if there's anything we can do to help support. If there's any work being done at your practices around a particular quality measure, or if you think that having some data support, some brainstorming, some education, please feel free to reach out. We're happy to partner with you really on anything, but particularly on these quality measures. Does anyone have any questions, comments? I'm happy to open the floor to my AHP colleagues as well.
Elizabeth, that was great. It's nice to see all the positive changes compared to last year. So I'm really glad that that new column is there. So thank you for making that happen. And then I thought maybe it would be a good idea to share the osteoporosis new project that we're taking on and maybe getting some feedback from the audience and asking if anyone would want to partner with us and putting something together.
Yeah, so do you want me to speak a little bit to
go
that?
ahead.
Okay.
Yeah.
So one of the things that we are committing to for the end of 2024 in a planning exploratory phase, and then for 2025, is working on the osteoporosis management for women quality measure. It's a STAR measure. We're partnering with Excellus on this, but certainly don't want to limit it to just Excellus patients. I'm not sure if everyone is familiar with the measure.
And we can send out all of the education and take care of that. I'm just thinking if anyone is currently working on it and they have anything that has worked well, or any barriers that they have had if they have tried to work on that measure on their own, but to know that we will be sending out education. And certainly if anyone wants to partner with us and in getting to some solutions, we would really warmly welcome that. And there's silence.
I was going to say, don't everybody talk at once. Feel free to email me, guys. You know how to find me. I'm happy to put my email in the chat just in case you don't.
Anyway, It's pretty exciting. Our numbers are not great, but that just means that we have opportunity for improvement. It's not an easy measure by any means, and there are some process issues to it. So we'll get there.
Excellent. Thanks, everybody. Thanks, Gina.
Thanks, Elizabeth.
Trying to find my unmute button. So As I mentioned, we're gonna also review some of the provider notification kind of cutoff dates and processes. Um, it is September, so we will be marching into roster submission season for our Aqua contracts and our value-based care contracts. So it's really important that throughout the year that you notify us, but especially now as we're planning for 2025, that we get information about the providers at your practice. So, a couple reminders. If you have a provider that's leaving your practice, please let us know. Really, when it comes to provider notification, our rule of thumb is if you would tell the insurers, you should definitely tell us. So as soon as you know that a provider is terming, whether that be, they're terming in a couple months, or if they're terming tomorrow, if they termed, unexpectedly that morning, just give us a heads up so that we can make a note of that. And if they are terming in the future, we will reach out to confirm the term date once it's passed, just to make sure that it's still accurate. This also goes for future plans. So something that we usually ask when we find out that a provider is terming is, what are their future plans? Are they retiring? Are they moving to another state or out of our network area? Have they started their own practice, or are they joining another practice? And so if you have that information, I know sometimes it's not always available, but having that information is very valuable to us and to you, because it does help us understand what should be done with their attribution and things of that nature. So it really is important that if you do have that information, or you're able to ask that information, that you do so and share it with us. Um, for larger practices, we do have a method that's been established for collecting rosters and provider changes. Cherie Turpin was working on that prior to her departure, and now we've got Jay Kim, who has taken over that role, and she's doing a phenomenal job. So you will hear from me and or Jay in some combination if we have that process set up with your practice. On the flip side, if a provider is joining your practice, let us know as soon as you know the start date. In similar fashion, even if they're starting at a future date, we will always reach out to confirm, hey, did they actually start at the practice? This is important because I'll talk about this a little bit, but it's not until the time that AHP knows. So even if they start in January, if you don't tell us until March or April, that's really the date that we have to go off of. So it does impact a couple things. We do not begin that membership process or contracting until they've started. So it does really help. So I'll talk about a couple things here. So APP specifically in the primary care, kind of space, we do collect information on all physicians, regardless of primary care or specialty. But when it comes to APPs, we really are only collecting APP PCP information. And the way that happens is we began enrolling APPs in the primary care space formally into AHP about a year and a half ago at this point. We do this a little differently than the physician. So all physicians are enrolled at the time that they join your practice. APPs are enrolled at the time that they have attribution to cover that initial $300 capital contribution. So that's why it's important for us to know about them so that we can submit them onto panels. And then as the year progresses, I work with Jim and our payers to identify those APPs who have enough attribution to become enrolled in AHP. This does make them, eligible for CI. It makes them eligible for the PCP reward plan. So there's a couple of things that are impacted by their participation status. Like all providers in the AHP network, physicians and APPs, when they're ready to come to join us, they have to go through membership committee and the board approval. So again, those dates happen 5 or 6 times a year at this point. So we really do need to, stay on top of that, because if we miss a date, the next one won't be for another few months. And so again, that can impact some roster submissions and contract eligibility as we go on throughout the year. So what we need, first, last name, NPI, an official start date. and an email address. As we move forward and we're really trying to engage more with providers around quality and some of the other initiatives, it does help to have a direct connection um, to the provider. Now, this isn't to say that we would be sending, emails erroneously, but for things and resources like pharmacy pros, which is really popular, when we send out high level quality performance, people want to be able to see that and we want to be able to share that. So we do ask for, the provider's email address. I know some practices don't have a work email for their providers and or some of their doctors don't check the work email. So if there is another email that they prefer, please just share that as well. Continuing on with the provider is joining your practice vein. As I mentioned, there are some limitations to when we can add providers to contracts. So for Excellus and Monroe Plan, 1/1 is the only date that we can actually add them to value-based contracts. And so for participation in the PCP reward plan, they have to be on the Excellus contract. And so, it's really important because we only have that one time a year that we do know about the providers. For MVP, we do get a couple start dates throughout the year, so we can start in January or July. So there's a couple different opportunities there. So as I mentioned before, it's when we're alerted of the provider starting at the practice, not necessarily their start date, that determines their eligibility or their contract start date. So again, if you have someone join in January and you don't tell us until May, there's some things that can be impacted. And so what that really looks like is, breaking this down very, very clearly. From January 1st through May, this is really going to be MVP inclusion. So this is when you notify us, but MVP inclusion starting for 7/1, and then Excellus and Monroe will be starting for 1/1. So if you told us in March of this year that you had a provider starting at your practice, their participation on the MVP contract will begin on it began on 7/1, and their Excellus contract actually begins in 2025. Okay, so they would be eligible for participation in the PCP reward plan for the 2025 reward plan year. So we're now in this next bucket of provider notification between May and October 14th. So if you notify us of a provider joining before October 14th, their MVP, Excellus, and Monroe contracts will all start 1/1/2025. This means that they will be eligible for the 2025 PCP reward plan. So you got about a month if you have providers who have joined recently or joining soon that you know about to notify us. I will also put in the caveat here, like I said before, if you know someone's going to be joining your practice in, let's say, November, you can let us know about that date ahead of time. We'll make note of it, but it does help us with pre-planning things like this. And when we do the roster submission, we do have a little bit of leeway there to include them because we were alerted ahead of time. So then what happens after October, 14 through the end of the year? So this is something, it's important, this one, because if you notify us October 15th, so let's say you had someone join in September, so they joined last week and you don't get around to telling us until the end of October. Their MVP contracts won't start for them until 7/1 of next year, and their Excellus contracts won't start until January 1 of the following year. So we're talking about 2026 participation in the PCP reward plan for clinical integration and all of those things. So it is extremely important, especially this time of year, that you keep us alerted to providers who are joining, leaving, any type of movements that's happening. Another thing that I didn't include here, but I'm going to toss it out there, is the importance of if you're changing suites, if you're moving locations, if you've got a new number, those are all updates that you can definitely share with us. While they don't impact as many things as the actual provider rosters that we need for our contracts, they do impact patient care. We have health plan members that we also serve through AHP. And so as we're updating our provider directories and our provider information, it is important that we actually know where you are. So if you have any changes in location or things like that that are approaching, please just give us a heads up about that as well. I'm going to stop there and ask if there are any questions about this. I think I also just saw 3 emails come through while I was talking about this, so I'm sure I've got some provider notifications waiting for me once I get off this call. Any questions? No. Okay. Is it based on when you were notified or their start date? Yeah, so it's when they're notified. So I'll take a good example here. It is September 18th. And so we actually had our board meeting last night and membership on Monday. So if we were notified today of a provider starting, the next date that they would be eligible for membership is actually October. We have a couple stacked ones through the end of the year. So if you tell us today that they started in July, their AHP participation start date, the earliest it could be would be October, and they would fall into these, to whatever bucket that's laid out here. So it really is a combination of when they start and when they're notified. Their AHP start date can differ from their AHP contract start date, and that's more of a back end thing on our end than what would impact you all. Is that helpful, Colleen? Okay, perfect. Are there any additional questions? Okay. So with that, I'll move into just some thoughts on some upcoming payments. So this time of year, and I've had a couple people reach out, we're usually about ready to pay out the PCP reward plan from the previous year. We're running a little bit behind through no one's fault. But we're at the time where we're beginning to calculate 2023 PCP reward plans. We're also working on second quarter clinical integration dollars. So at this point, I'm expecting those payments to go out sometime in October. If we hustle, we might be able to get to them, a little earlier, but I would expect those payments to reach you guys in October. Not usually any questions on this topic, but I will pause for a second if there are. No. Okay. As promised, short agenda. So we're going to move right into open discussion. I hope LJ has popped back on because one of the questions she has not. So I'll move to the second question, or really comment. We sent out an RSV survey regarding RSV prophylaxis a couple weeks ago, and we've done some follow-up. That survey is closed. We got a really good response rate, but I just wanted to know and open it up if people had questions about that survey, if they had questions about, RSV prophylaxis in the region. So I'll pause there and ask questions if people have them. No, it was pretty straightforward. I thought it would be. The other thing that we were alerted actually by one of our pediatric practices about some changes happening in Wayne County around school forms for things like self-carry medications. They actually have the process that a nurse fills this out, and I'm sure that's the process for many people. However, we are hearing that New York State is introducing a new process where the physician actually has to sign that, and it has to have the doctor's name on the form. So that does impact a couple people's workflow. We're expecting that if it's a New York State kind of regulation, that it'll expand to other school districts and counties. But I just wanted to open up the floor and see if anybody else is experiencing this, and where you are, if you are. No, so it has to be a physician. It has to be a physician is what we're hearing. So, um, I think this has become this has become a little bit of a sticking point because they are saying explicitly there has to be a physician signature on the self-carry forms. So we're doing a little bit of research here. Right now, we're only hearing about this in Wayne County, but they've expressed that this is a New York State kind of mandate that's being pushed out, so they are expecting expansion. I was hoping to have LJ on this county on the back on the call. I know she had to hop off because she's also exploring this here in Monroe County to see if it is, in fact going to come here. So it's a range of forms. So anything PTDs, self-carries, all of those school forms that require physician or, the primary care office's signature on for the school, they're saying they need to be signed by the physician. But it sounds like our folks here in Monroe County are not currently experiencing this. Or in Livingston. Okay. So we'll share more information as we get more information on that. The question was broached kind of while I was on vacation and came back to it. So we're doing some exploration now. And if we find that that is going to be an expanding criteria, we'll definitely bring some clarity there on who exactly can sign and which forms are, they're applicable to. Those are the topics that I kind of wanted to talk to about the group. What are the things that are on folks' minds? Do you have questions about relative to AHP, quality, all of those things? And feel free to unmute if it's faster than typing something into the chat. I think I gave the full 30 seconds. Oh, someone has just sent a question actually about the issue that we're experiencing with the immunization data. Elizabeth, did you want to touch briefly on that?
Sure. So it's certainly one, possibly two issues. The one we don't believe has a big impact. The first one is when looking in Arcadia, we've traditionally worked on childhood immunization combo 3, which is just the naming convention. It has like 1,000 vaccines that are required, but childhood immunization combo 10 includes everything in combo 3 plus Hep A and flu. We have not taken that one historically because flu vaccines are really, really hard to track. One of the questions that we have up with Arcadia right now is whether or not the back end, it's displaying combo 3, but when you hover over it, it gives the definition for combo 10. So we want to make sure that they're using the correct measure definition. We did take a look. It only impacted about 20 patients with that shift, but still that's important for us to make sure that they're, calculating it based on the correct definition. The second is there is a code being used that for one of the combination injections that has been reviewed, confirmed. It's included in the measure set as things that satisfy the measure for next year. It's not included in this year's definition. And so it should be, or, they've approved it for next year, but it wasn't a part of the measurement year 2023, which is the definition we're using now. So Excelis is comfortable with the idea that that should satisfy the measure. The question we have is whether or not we can update Arcadia or if we need to have a manual adjustment at year end. So that's the open piece. And also then obviously what the shift in performance would be. We don't have that information yet. But happy to share that out with you all when we get it. We don't need to wait for another practice managers meeting. So I'll coordinate with Gina how to communicate that once we know a little bit more. It's not something I'm overly concerned about because I do think that we have general agreement that there is an issue and that we know what we want the fix to be. Now it's just making sure we get that in place.
I got a thumbs up to the message, so I think that was sufficient. Thank you,
Thank you.
Elizabeth. Are there any other questions before I move on here? Okay. So we're rounding out the year here with practice managers meetings. We have one more scheduled in December, so that will be the next time I see you all in this forum, though I'm sure I will talk to many of you, if not all of you, before then. So we will see you back here Tuesday, December 3rd at 8 a.m. to 9 a.m. We will also send the information from today in the slides. One of the things I will also include is a brief plug. MCMS is doing their provider survey. So if you can share that with the docs at your groups, that would be lovely. We will also, I'll talk to Angelique and Elizabeth to see if there's anything on the osteoporosis project that they would like to share out. And we will get that information to you. A reminder, yes, you are in AHP. We are coming up on open enrollment 10/16 to 10/30. So as people are looking for doctors, you want to remind them that you are an AHP provider. This is how they get the most benefits out of their benefits. So make sure that you and all the folks answering your phones know that. Whenever you can, refer to an AHP specialist, AHP hospitals, and AHP imaging locations. If you have any questions about who those folks might be, just reach out and we can assist. For your practice managers, keep attending this meeting. It's very, very helpful and informative when you do so. Please accept and read and share AHP communications. They apply to various people and various things. And so it's really nice when you can do that. If you unsubscribe from one, as I like to remind people, you have unsubscribed from all. If there is anyone saying they're not getting AHP communications, please reach out. Whenever possible, help your providers connect to AHP resources. So we do have a variety of those. And if you're ever wondering, just ask and we'll get you connected. I've added in contacts and updated those here. We will share this so you have this, but these are all of the primary contacts here at AHP. So if you have any questions about any of the topics, please just let us know. I did not include social work because all of you who, or really care management, all of you who have care managers in your office, you know how to find them and how to find their supervisors, and that's a really long list. But if you ever have any questions about that either, you can reach out to myself or your care manager and we can chat with you. We also have some other contacts for RMS Healthcare, Medline, and then Atlantic Health Partners. So please, if you have questions about these services as well, you can reach out directly to them or you can reach out to me. Yes, we will be sending out the presentation from today's meeting, but that is the end of our agenda. And as promised, short, simple, sweet.